Hello friends, welcome to a new lecture today on one of the important topic in gynecology, which is dysmenorrhea. It is the most common problem which is seen among young girls. So here, what is dysmenorrhea? Dysmenorrhea means painful menstruation. Okay, so this dysmenorrhea, it can be classified into two types, which is spasmodic type of dysmenorrhea. The first type of dysmenorrhea is spasmodic type of dysmenorrhea, and the other type is congestive type of dysmenorrhea. In spasmodic type of dysmenorrhea, if this is the menstruation, okay, and this is the other one, so it starts with or just before the menstruation. It starts with or just before the menstruation, and then it peaks and then it decreases. Okay, so this is spasmodic dysmenorrhea. Whereas congestive dysmenorrhea, here this is the luteal phase. Okay, this is menstruation. Okay, in 1 or 2 days it will disappear. Okay, here it starts in the luteal phase, and it increases in menstruation. It increases and then it decreases. Okay, so this is congestive type of dysmenorrhea. So if you see in spasmodic type of dysmenorrhea, it is colicky pain and it is present suprapubic, whereas congestive is constant pelvic pain. Spasmodic dysmenorrhea is usually primary dysmenorrhea. Okay, so dysmenorrhea can be again divided into two types. This is first classification. Classification 2, the dysmenorrhea can be divided into primary dysmenorrhea and secondary dysmenorrhea. Primary dysmenorrhea is that occurs before the age of 20 years, and it is usually spasmodic. Okay, if this is the abdomen, these are the legs. Now the dysmenorrhea, it starts in the suprapubic region and it radiates to thighs and also to back. Okay, it starts in the suprapubic region, the pain, it radiates to thighs and also radiates to the back. It can also be associated with other symptoms. Okay, in primary dysmenorrhea, you don't see any pelvic pathology. There is no pelvic pathology. Okay, then this can be associated with other symptoms. What are the other symptoms? It can be associated with nausea sometimes, or vomiting, or diarrhea, or syncope. It can be associated with nausea, vomiting, diarrhea, and syncope. Now, what are the risk factors where it is more common? It is more common before the age of 20 years. It is also common in nulliparity or early menarche. It is common in early menarche, nulliparity, or if there is heavy menstrual flow. Even then there is increased spasmodic dysmenorrhea, or if there is increased duration of menstruation, even then there is spasmodic dysmenorrhea. Okay, or anxiety and stress. In such cases there is spasmodic dysmenorrhea. So this is about the primary dysmenorrhea mostly, and then secondary let us learn about secondary dysmenorrhea. And the primary dysmenorrhea, it is mainly due to the prostaglandin 2 alpha level. What happens is, after ovulation, let me just write the pathogenesis of primary dysmenorrhea. Primary dysmenorrhea pathogenesis, we have after ovulation there is increased progesterone. Okay, this progesterone will activate phospholipase A2. Okay, this will activate phospholipase A2. So this phospholipase A2 will convert phospholipid to arachidonic acid. Okay, it will convert phospholipid to arachidonic acid. This will lead to prostaglandin F2 alpha production. This will increase the tone of myometrium, and thus it causes myometrial contractions. Because of this myometrial contractions, there is ischemia to the blood vessels and vasoconstriction. This will cause pain. So this is how we get pain during primary dysmenorrhea without any pelvic pathology. Then let us learn about the secondary dysmenorrhea. Secondary dysmenorrhea, it is associated with pelvic pathology. Okay, and it occurs more than 20 years, several years after menarche it occurs, and then it starts before menarche and increases with onset of menarche. So it is something like a congestive type most commonly. It is just most commonly congestive type. Okay, it increases with onset of menstruation. Now, and there is, you see, pelvic pain here in the pelvis, pelvic pain, and there is also backache. Okay, in this secondary dysmenorrhea, there is pelvic pain and also there is back pain. And now, what are the causes? There are many number of causes for secondary dysmenorrhea. So it can be due to endometriosis, because of endometrial deposits in other areas other than the uterus. This will cause very much increased prostaglandin F2 alpha, so obviously it leads to pain. And it can be due to adenomyosis, okay, or pelvic infection. Obviously in infection there is inflammation that causes inflammatory changes that will cause pain. And if there is fibroid uterus, obviously in fibroid uterus there is local congestion, okay, because of the mass that causes pain. And ovarian masses or pelvic congestion syndrome or any pathology in our gynecology which will cause pain, okay, all those will cause secondary dysmenorrhea. Now how are you going to evaluate it? First you will take the history. In the history you will take about the age of the patient, age at onset, age at menarche, type of pain, whether the pain is spasmodic or congestive, that should be taken into account. You'll have to look after the location of pain, where the pain is exactly located, and also other symptoms like gastrointestinal symptoms, syncope, heaviness in pelvis, backache, and also menstrual cycles. Menstrual history should be taken. In the menstrual history, you'll have to take about the duration of flow, amount of flow, regularity, parity, whether there is any dyspareunia, or impact of this menstruation on day-to-day activities, even that should be taken. Clinical examination should be done. In that you'll have to do per abdominal examination. And you'll have to also do about the pelvic examination to see the uterine size. If there is any mass, that should be seen. And then perectal examination is needed to see whether there are any rectovaginal nodules or whether there is any tenderness. Then you'll have to go to investigations. For secondary dysmenorrhea, you'll do some investigations like ultrasound examination. It can be transvaginal or transabdominal to find out the masses in the uterus like leiomyoma, or whether there is any pelvic or adenomyosis, or whether there is ovarian masses, or if there is cervical stenosis. In such cases we do ultrasonography. You can also do sonosalpingography. Okay, even Mullerian abnormalities, even that causes secondary dysmenorrhea. Okay, Mullerian anomalies. Okay, so sonosalpingography, this is done mainly for intrauterine lesions and also for Mullerian abnormalities. And then you can do laparoscopy. Laparoscopy is mainly done for endometriosis and also if there is any chronic pelvic inflammatory disease. In such cases, you can do this. Investigations. Primary dysmenorrhea can be managed, but secondary dysmenorrhea is treat the cause. In secondary dysmenorrhea, you'll have to treat the cause, but there are some drugs which will help in primary dysmenorrhea. In primary dysmenorrhea, you can give NSAIDs, any type of NSAIDs. These NSAIDs, because the main problem is in the increased prostaglandin F2 alpha. If this pathway is inhibited, then obviously the pain will decrease. So we give NSAIDs. NSAIDs will inhibit the phospholipase A2, and thus it inhibits the conversion of phospholipids to arachidonic acid. So here NSAIDs will increase, will act. So as a result, there is decreased dysmenorrhea. And then you can also use progesterone intrauterine system also, because there is increased progesterone. So when you use this progesterone intrauterine system, then increase in progesterone after ovulation, that will decrease, and as a result the pain will decrease. And then there are other surgical management also, like uterine nerve ablation or presectoral neurectomy. Those will be done, but they are in extreme cases. But mostly primary dysmenorrhea, it can be treated with drugs, and that too giving NSAIDs, any type of NSAIDs. It may be methylamic acid, ibuprofen, naproxen, anything can be given. So this is about the dysmenorrhea. I think you guys have understood something about dysmenorrhea. Thank you for watching my lecture.